us by asking one simple question: what is a community of practice? So, as we say, in its simplest terms, a community of practice can be looked at as a community of people coming together to share some concerns, or those persons who have a passion for something that they do. And when they come together, in so doing, they learn how to do things better once they interact regularly. So, this interaction or information exchange brings an opportunity for personal and professional development. Today, we are here on an adventure in Caribbean information systems for health and digital health, as we co-create a community of knowledge and information sharing in a common space, a community of practice. On our agenda today, you will hear from a mix of speakers who will explore the theme: Health Information Systems, a Pathway for Better Decision Making. I will now go ahead and take us through the agenda, um, which, as I said, comes together with a number of persons who would have you would probably know in the Caribbean landscape. So we'll begin with a welcome and an opening remarks from our director, Dr. Althea Lafourcade. She's the director of the AGU Center for Health Economics. Then we would move on to Dr. Prabjot Singh, who will deliver remarks. Dr. Singh is from Paho, Barbados. And then we'll go into some presentations. At the presentations, you will hear a little bit more about health data and how we use health data for decision making, how we use health data, and we employ health information systems for development. And then we would go into a question and answer session. And then from there, we'll take you into a little bit more about the CARISHCA, the Caribbean Information Systems for Health Community of Practice. So we'll hear a little bit more about it and some of the details behind the development of that CARISHCA. So we have an exciting agenda ahead of us. So I wish you an exciting certain time today in our session. And I would now like to turn you over to our director, Dr. Althea Lafourcade, who would bring some remarks at this event. Dr. Lafourcade, it's over to you.
Good day, friends, esteemed colleagues, ladies and gentlemen. Today, I'm keeping it brief. I would say a few words to you, welcoming you here and indicating a few of our thoughts pertaining to the adventure, Charmaine called it, of this community of practice for information systems for health. And I'm hoping what would happen as we explore and we develop this community is that we will get an opportunity to continue exploring some of these issues that will be raised this morning. That being said, this morning, I want to begin by saying that in economics, there are some basic principles that guide the discipline. And we have some curves, some of them things that we call indifference curves that tell of preferences. And a fundamental requirement is that those curves never touch the axis. They could go very close, but they would never touch, because consumption of the commodities in question must never reach zero. This concept is stark when applied to the health sector, because it aligns with the understanding that health is not everything, but without health, life is nothing, according to Swartfield and Bright. It further points to the critical importance of access to health and health care, and illuminates the pathway between the stock of health, well-being, and development. Over the decades, our countries in this region have shown a concern and desire for the population to have proper, effective, and efficient access to health care. We also have clear evidence over that time of the recognition that policies, practices, and related arrangements impact this access. In this regard, we have had calls for greater emphasis on measurement, monitoring, and evaluation. knowing where we are, where we want to go, and the distance from here to there. The view being that with given objectives, it makes sense to track how the manner in which we are conducting our affairs is taking us closer to or further from achievement of said objectives. But this is where information steps in. Information is critical to achieving, maintaining, and or improving the health staff. Information on what is happening, where it is happening, to whom it is happening, how we respond, barriers or obstacles to the response, and the results of the response, etc. Thankfully, our countries have all demonstrated an understanding of the pivotal role of information systems for health. Moreover, we continue to benefit from strong support, guidance, and collaboration from key agencies and organizations, including the PAHO, the IDB, the CAFA, the GSI, USAID, and many others. The university is happy to be part of this initiative. And this brings us to a common saying that we have adopted in the Caribbean. It takes a village, or the all hands on deck approach. This information systems community of practice recognizes and would want to draw on the village concept as demonstrated by the diversity of the participants at this webinar. With this being said, I look forward to the session, and I hope we all have a productive engagement this morning as we launch this community with an exploration of some critical issues related to health information systems in the interest of our beloved region. Thank you, and I now hand you over to our chair, Ms. Metiver, Ms. Charmaine Metiver, Research Fellow at the UWI-HEU and Interim Coordinator of the Health Information Systems Technical Support Facility. Ms. Metiver.
Thank you, Dr. Lafayette. So we now go into our first speaker, who is Dr. Prabjot Singh from Barbados. Dr. Prabjot Singh is the advisor for health surveillance, disease prevention, and control based in PAHO office in Barbados and the Eastern Caribbean countries. In his current position, he focuses and has been focusing on strengthening information systems for health in PAHO member states, especially those of the Organization of Eastern Caribbean Countries. He's an epidemiologist and a medical doctor by training and has been working in the Americas for over 15 years. We now invite Dr. Prabjot Singh to bring remarks. Dr. Singh, it's over to you.
Thank you, Charmaine, everybody. I am Prabjot Singh, for those who do not know. I am based in PAHO, Barbados, and the Eastern Caribbean countries. I look over quite a bit of the countries that we are under the multi-country office. And currently I am joining from India. I'm in vacations right now, so please don't mind the background noise or if you see any yawns, because it's almost 8 p.m. around here. Thank you all for joining on this busy day. I know many of you have very busy lives and making time for joining us on this first meeting is exemplary. And I know most of us have had experiences with information systems. Some of you who might be old enough as me would know the floppy disks, which are 8-inch or 5-inch in sizes. Some others who are younger enough would have been introduced to the ASBs, and the older ones than me would probably know the floppy disks and the punch cards from those eras. And right from that time, when the introduction of computers was being done, it was being expected that, well, the introduction of computers will transform and digitalize healthcare. But it's been more than 20, 30 years, and we're still kind of struggling. COVID-19, the pandemic, which really led to a rapid digitalization in the Eastern Caribbean countries, was still a sobering experience for many of the countries. I saw in many of the countries, while they were trying to use most of the digital methods that you can think of, using WhatsApp, using Google Sheets, etc., but still data was being shared as PDFs and copies, and then transcribing and digitalizing, and then still sending it upwards. And there was so many inefficiencies in the systems and the ways they were using. It was very evident that there was a need for a larger, bigger push towards rapid digitalization in a more efficient manner, such that we are able to match the needs of the countries. And while during the COVID-19 pandemic, we had a talk with Bishu from USAID, who was exploring and having some brainstorm sessions about whether or not a DHIS2 hub would be feasible to be installed in the Caribbean, and even so, where it would happen. And at that time, we had a lot of discussions. We saw that the countries had limitations, but when you put the sum of all the countries' capacities together, it did lead us to the idea that a digital revolution is possible, and it is what we want. For instance, there are varied systems being used currently. For the labs in the Eastern Caribbean country, at least 4 of them use the same Skylab, which is a platform that we use for our lab information system, in varying degrees of implementation. Yet 2 others are manual and are completely manual, and one uses DISA. Or for instance, in case of electronic health records, Populous is being used in St. Lucia, it's being used in Barbados, St. Vincent and the Grenadines, even Belize. But again, it's varied degrees of implementation and little to no talk between the countries as to what are the challenges, what have they faced, and what are they doing with these systems. Or, for instance, DHIS2 for surveillance that is being used in various stages of implementation and also for different areas of implementation. But all of this that I've just said is just health information system. But digitalization in health is much more expansive, be it telehealth, be it knowledge management, or just how you as a medical doctor, as a nurse, or another person in the health sector is applying for leave. That itself requires digitalization. And that is what we call information systems for health. That is where we come in with information systems for health. It is much more broad. Yet those who are implementing these varied systems, the governance model that is required, the pillars that are required so that these systems are in place, the standards that have been set up, are all of those areas which are still being dealt with 2 or 3 people at max in each country. And all of them have their own challenges, yet there is quite a bit of overlap in the challenges that they have. So we need a forum. We need a forum to bring this knowledge together and for networks to be formed. We need to harness the know-how each one of us has. We need this knowledge to flow from one country to the other so that people can meet their needs. While PAHO has many of these networks already formed before COVID pandemic, the Caribbean Information Systems for Health network, there is still space to have networks so that the nitty-gritties of these can be formed, can be discussed. And this is where while we were brainstorming, the University of West Indies came into mind, which was narrowed down as probably one of the areas, one of the institutions which has a good reputation all across the Caribbean, which has the know-how and which can probably help us in the countries and the ministries to form these networks, to have this information flow between countries altogether. And that is why we are today joining, all of us from PAHO side. I see Marcelo somewhere on the scene. I wasn't sure he would be there, but hi Marcelo, and others who are here from other entities. I'm not sure if USAID is there, but probably they might be, and others. It is very good to see all of the institutions, the stakeholders, the partners to join, to form, and to be part of this initiative. Back in 2023, if I'm not mistaken, in November of 2023, we were able to bring many of the institutions within PAHO, many of the entities within PAHO who have been working in silos on different aspects of the information systems in the Caribbean, in the ECC at best, I should say. But even then, when we tried to do this, we found that there are many other entities who are bringing together. And today, as we form this network, we are hoping that other countries, the countries would join, and stakeholders would join, including CARFA, including UBI, including USAID, and many others who are participating in this. So thank you all for those who have joined, and looking for a fruitful discussion.
Thank you very much, Dr. Singh. It was really good to hear you talk about all of the partners and what we have going for us in the region, because we really do have many things that happen and go in our favor. We just need to know how to harness it and how we need to put it together so that we can get better results out of them. So thank you for bringing those remarks and for reminding us of some of the things we have, but also telling us about what we can do even better. Thank you for that, Dr. Singh. We now move on to our first of the presentations. We have a presentation by Mr. Osbert Josiah, and he is from the Leicester Medical Center at the Ministry of Health and Wellness and the Environment in Antigua and Barbuda. And today we will speak to us about health data for better decision making. In terms of Mr. Josiah, he's an experienced professional in health-related information systems implementation with over 14 years experience in the field. He holds a master's degree in management information systems, systems security from Anglia Ruskin University in the UK, and a Bachelor of Science degree in information technology and education from Skidmore College in the USA. Currently, Mr. Josiah serves as the IT manager at the Celeste Bird Medical Center in Antigua, where he oversees the implementation of IT systems. He's also responsible for the data systems for the cervical cancer elimination and the COVID-19 vaccination programs within the Ministry of Health, and is involved in the DHIS2 implementation. Currently, he also serves as the project lead for the upcoming implementation of hospital information systems at the hospital and clinics in Antigua and Barbuda. When he's not working, he enjoys cycling, gardening, and sleeping. So on that note, I'll turn you over to Mr. Osbert Josiah.
Madam Chairperson, Ms. Shamin Metivar, Dr. Lafayette, Dr. Singh, and Dr. Brathwaite, all esteemed guests and colleagues, good morning. And the most important part in that bio was the enjoyment of sleep. Doesn't come very often. So today I'm tasked with presenting on the topic health data for better decision making. And that has to do with our hospital information systems. To begin, I'd just like to look at some quotations on the matter of the importance of data. So one quote says that data is the new oil. We've heard that before. With data collection, the sooner the better is always the best answer. That's from Marissa. Andy Dunn says that passion provides a purpose, but data drives decision. Without data, you're just another person with an opinion. That's from Edwards Deming. Daniel says that you can have data without information, but you cannot have information without data. Data is the new science. We have heard that a lot of times, and big data holds the answer. Data really powers everything that we do, says Jeff. And one of my favorites, in God we trust, all others must bring data. So all of these give us the idea that persons recognize the importance of data. And just to give an illustration of how important data is, many of us, we like to travel, and so we like to take a flight on an airplane, and there goes my airplane. And usually on the airplane, we're not too worried. We're usually comfortable, we're relaxed, we're enjoying the flight. What if you were told, however, that your pilot was basically winging it, for pun intended, he's on a plane, but he was winging it. He didn't really know how high he was. He had no idea the speed he was traveling in. He had no idea the direction, nothing really. He was just gonna, let's see what happens. And as soon as he sees a runway, he would try something. well, your reaction would be something like this, because that's it, you know. But fortunately for us, the pilot has at his disposal a host of instruments. In fact, instruments on both sides of the plane. And so these instruments feed him data. And he's fed data such as altitude, airspeed, air pressure, temperature, humidity, precipitation, vertical speed, aircraft heading, relation to horizon, turn and slip, rotation along the longitudinal axis. We have no idea what those last two are about. And some sort of reading or data that the pilot tells us to, you know, take our seats because there's about to be some turbulence and much more. And so this underscores the fact that data is important. And so once there's that data, we feel safe. Data is also important in healthcare. And so we look at the importance of health data. Now let's see what some officials have said. Beginning with the WHO declared that a health information system is the structure for the collection, processing, analysis, and treatment of information necessary for the organization and activity of health services, as well as for research and teaching. Chris Brooks says that the health information systems help gather, compile, analyze health data to help manage population health and reduce healthcare costs. And also the healthcare data analysis can improve patient care. The former commissioner of New York City Department of Health, Tom Frieden, he is quoted as saying that the way we work in public health is, and we all know this, we make the best recommendations and decisions based on the best available data. Data is important. And finally, health data has led to better decision-making in policy formulation, resource allocation, and program implementation at scale. And so clearly, data is important, and health data even more important, especially in making decisions. Now, I'd like to share two examples that show the importance of data to decision-making. The first one is the use of the perinatal information system, or the SIP, which is used in many of our countries for maternal health. And so there's this example of how it could aid in decision-making. Colloquially, or in our countries, we have a saying, or we conclude that the peak time frame for baby deliveries in our hospitals is 10 months after Carnival. I'm sure we've all heard that. And so in Antigua, if Carnival is now, which is late July, August, then we would say that would take us to about April, May. My math might be off, but I'm giving it 9-10 months. So what can we do with that information or that knowledge? Well, we can improve or increase our PSAs on safe sex during Carnival. We can distribute contraceptives during Carnival, because that's what we're targeting. In the hospitals, we can increase the number of OBGYNs and midwives, because the sooner a mother gets care, the safer the outcome for both mother and baby. We can even add a delivery room or two. And so we feel well prepared for this event, or well, for deliveries. But Jim Baxdale says that if we have data, let's look at data. If all we have are opinions, then let's go with mine. Because we said that this is a common knowledge. So let's see what the data actually says. If we look at this chart generated from SIP data in Antigua and Barbuda, the first dot being January, we see that the peak births actually occur in September, October. Not what we thought, because now we have data. And so if my math is correct, we would say that the conceptions took place December, January. And so our guilty time period would be Christmas or New Year's. And so it's totally different from what our common knowledge would have told us. Again, underscoring the importance of accurate data. and how we can use now this accurate data. So we know when we now have to have our midwives, have our OBGYN, when we have to have our extra delivery rooms and so on. We have an accurate idea and not just what we thought. It was no longer our collective opinion. A second example was a recent program, the Cervical Cancer Elimination Program, which the Ministry of Health in Antigua and Barbuda embarked on in September of 2022. We started a pilot, 5-month pilot, during which over 1,500 women were screened for the presence of HPV. And not just HPV, but high-risk HPV that would put a woman at risk for cervical cancer. So the data for the pilot after this 5-month period was analyzed, and the following was found. Persons who needed a triage step or some sort of treatment took about 60 days to get the treatment following the procedures that were in place. There was also a high uptake during the weekend screenings, and certain groups of women were underrepresented. So, for example, women who were HIV positive and who did not speak English, their presence or the numbers were extremely low. And so this data gleaned from the pilot program then led to some changes. So during the scale-up, the algorithm was changed to be more efficient or to include more efficient management timelines. And so what they were able to do, the team was able to reduce treatment wait time from 60 days to 30 days. And so a woman now could get the life-saving treatment faster. And then as the data comes in, it can probably even be reduced more. The creation of more opportunities for women to access screenings. And so instead of ad hoc weekend screenings, regular weekend screenings could be planned. This is because a lot of women work Monday to Friday, 8 to 5 during the times of the screening. And then the development of targeted outreach programs to improve uptake. And so we could now target those persons who are underrepresented by going to the organizations that would represent these ones. So this is a second example of how data in healthcare is important in decision making. Now, you can't mention data, health data, without mentioning what PAHO has done. And so PAHO has developed a framework or mechanism called Information Systems for Health, or the IS4H. And what this does, if we were to visit the PAHO website, is because they recognize the importance of data in healthcare and decision-making, this tool was developed. And this tool allows us to look at data from different sources and use that data to implement better decision and policy-making processes. One section of the IS4H mechanism or tool framework is data management and information technologies. And this looks at IT infrastructure, data governance, standards for quality and interoperability, information products, and data sources. And here we have a picture of this from the PAHO handbook or the tool itself. Again, we could get this from the PAHO website. It's available for all. Now, it explains each section, but in the lower right, it has the outcome. What is it we intend to achieve? So if we were to zoom in, it says health data that are analyzed and published in a variety of formats that support decision-making needs and health system stakeholders. And so this is what all of us want to achieve when it comes to data. So if I were to categorize data, I would categorize data, I would have 3 categories. And the first category is data that is used to diagnose and treat a patient. That's our blood pressure, that's our blood tests, our radiology scans, all the investigations, questioning the patients, that immediate data. Then we have data used to make policy decisions regarding resource allocation and procedures or algorithms, such as what was mentioned before. That's when we put all the data together, see trends and outcomes, and we're able to now make decisions. And then there's data for research. And this data for the results from this research feeds back into the other two, because based on research, we know how to better diagnose, how to better treat, and how to better allocate resources and come up with procedures and policies. Now, how a community of practice will be beneficial when it comes to data, or just an example, I would like to now share this with you. Now, there's the ability or the potential for knowledge sharing and dissemination, collaboration and innovation, capacity building, standardization and quality improvement, evidence-based decision-making, enhanced data utilization, policy and advocacy, feedback and continuous improvement. Now, let's put this in a real scenario. Well, it's a simulated scenario. Let's say that the scenario is we want to reduce hospital readmission rates in a particular hospital within the community of practice. The members of the COP would then be able to share data on readmission rates from various hospitals, various countries, along with the associated factors. What are the patient demographics affecting this? The discharge procedures at the different hospitals. Collaboration, where the interdisciplinary team would analyze the data to identify the common factors that contribute to the high readmission rates. Then members of this team would then look at successful strategies that have been implemented within or by members of the community of practice to reduce readmissions, such as enhanced discharge planning, follow-up care, and so on. Standards. The COP would then develop standardized discharge protocols based on the best practices that would be identified. Notice so far, no one is on their own. It's an entire community coming together to solve this problem. Workshops would be held to train hospital staff on the new protocols. Hospital would implement the new standardized protocols. That's the implementation stage. And then once that is done, it will be monitored. And so there'll be continuous data collection and monitoring to assess the impact of the new protocols. And once this data comes in and this data is analyzed, then there will be feedback from this implementation phase that will be shared with the community of practice, which could lead to further refinements and improvements to the benefit of all persons involved in this community of practice. So this was just a simulated example of how data would help in the decision-making process within a community of practice, such as the one being launched today. So to close then, I would just, like we started with some quotes, so I would like to end with a quote, and it's from David, and he says, "Information is the lifeblood of medicine, and health information technology is destined to be the circulatory system for that information." So that is something we can all take to heart, we all agree with, something that we see going forward. And I would urge all of us to continue to see how we can use data in making proper decisions, setting policies for the benefit or the improvement of healthcare, not only within our region or within our country, but within the entire community of practice. And I think the plane successfully landed, not sure. Okay, that's it. Thank you.
Thank you, Albert. I think your plane is taking off, and you've taken off after a successful presentation, and I thank you. For persons, just letting you know that there will be a question and answer session after the second presentation. So make sure to have your questions together, put it in the chat, and they'll be addressed after the next presentation. So we move on to Dr. Ricky Brathwaite. Dr. Brathwaite will be presenting on health information systems for development. Dr. Brathwaite has over 20 years of experience in engineering, healthcare research, analytics, and health information systems. He focuses on health systems in the Caribbean, Latin American island nations, as well as large countries, ensuring systems optimize their economic frameworks, technical infrastructure, and strategic fundamentals for comprehensive healthcare. Dr. Brathwaite has been instrumental in developing and implementing health information systems that enhance data standardization, health technology assessment, and digital health strategies. He has led international efforts to improve healthcare quality and reduce costs, advised government leaders on health strategies, and managed diverse teams at the Bermuda Health Council, where he is the CEO. His works involve using health information systems to streamline health data, improve patient care, and support health systems reform. Dr. Brathwaite holds a PhD in economics from Johns Hopkins University. He also has a master's in health systems, industrial and health systems engineering, a master's in bioengineering from Georgia Institute of Technology. His work spans academic, community, government, and private sector, providing thought leadership, technical recommendations, and strategic planning for health programs, with a strong emphasis on leveraging health information systems for program goal fulfillment. So with that, I'd now turn you over to Dr. Ricky Brathwaite for his presentation.
So good morning, everyone. Hope everyone can see my slides. I did want to take the opportunity this morning to, one, thank UE for the opportunity to talk about health information systems, and also go back a little bit where some of the conversations around health information systems for at least myself and the island of Bermuda started with PAHO and a lot of conversations around how to define health information systems and how to make health information systems work for our countries and the objectives that we're trying to reach. And one of the things I always remember is some of the representatives from PAHO always saying that health information systems aren't about a digital platform. They aren't about an EMR. It's bigger than that. It's about all the information that you receive within a system that helps you to either develop or make better decisions for what you're trying to accomplish, which hopefully for all of us is better health for our countries and the region as a whole. So today I just want to give you a snapshot into some of Bermuda's health information strategy and what we're trying to accomplish as we move forward towards a more modern system towards the end of this decade. So the Bermuda Health Council, which I lead, is a regulatory and enhancement organization within Bermuda, serves as part of the leadership structure of the health system. Our objective primarily, and I think it's very important to talk about objectives and to ground ourselves in what we're trying to accomplish. So as an organization, we're looking to enhance equitable access to quality healthcare services within Bermuda. And our process of doing so includes things like regulation, coordination of healthcare within our health system, policy development, and advocacy within our health sector. And why it's so important as we look at our health sector, there's a lot to do. There's always a lot to do in healthcare. We've created this graphic to talk about, as we've talked about our health system, to talk about what's not working exactly well. What are some of the projects we need to work on? So if you look at the middle of the screen, there's a circle that looks like a number of bubbles. And within every one of these bubbles is the types of projects that we know need to be worked on to get to our ultimate goal. And our ultimate goal is to have improved health within our health system at lower cost. And one of the key things I want to point out today, and it is one of our key objectives, is around quality of care. How do we develop a health system that focuses on quality, that leads to better health outcomes for every person within our community, regardless of age, sex, income, gives people a chance to be as healthy as possible, and gives the providers who are providing services the support they need to provide quality healthcare services. And one of the things when we look at quality, quality is just not it's not a simple thing to measure or to determine how we're going to reach it. So if we look at some of the frameworks that are out there, I've looked at this framework, and it does take into consideration Donna Bedian's triad for health, which is around structure, processes, and outcomes. And it's a lot of conversation around that. How do we ensure that we have the structure that's in place, the processes, and that we're achieving the outcomes to say that we're able to say that we've done what we've needed to do in terms of quality. And then when we talk about quality, there's a whole lot of the layers. And one of the layers of that is, how do we use technologies and providers and patients and payers and professionals, the kind of the touch points within our system that touch the patients in a patient-centered way. How do we use those various things to come up with a better healthcare system? And so since we're on the point of quality and we have a framework for what quality means, one of the things we always thought we'd do is leverage our transaction, our administrative data within our system here in Bermuda. So when we talk about quality, one of the major things that we started with is to look at what are our reimbursement and our administrative claims data that we receive, and how can we use that to better assess or to forecast what we're going to need in terms of a better structure for the system, better processes, and to really understand what the system needs. So if you just look at this page, there's a lot of numbers on here, but what this can tell me is how much we paid for a certain service. It can tell me what the diagnosis code was for the individual that was serviced. It can tell me whether the service was done on island or off island, what specific procedures were done. And while that has been okay for quite a while, as we've learned more about the information we need to get to the point where we can properly understand our quality of services that we're delivering on island to develop a better health system, we've realized that administrative data is not enough. And while I was at a conference 2 weeks ago, that was reinforced that not only is administrative not enough, we need more input from the clinical notes. We need more input from the clinical systems to really put together a picture of what's going on within our systems. And so as the Bermuda Health Council, we've expanded our health information systems ecosystem from just administrative data to thinking about a strategy for how we're going to use our various pieces of health information to solve our problem. Again, the problem has to be rooted in something, and our problem is rooted in how do we achieve better quality. So we've done various things. We've taken our data and we've run it through various analytics programs such as Power BI to use as a tool to display our data better. We've leveraged our website that is public facing to be able to share information with the public. We've looked at, if we're going to ensure that there's compliance with quality standards, how do we ensure that we are monitoring the inspections of that compliance? So we've done things like layer on inspection software. Recently, as we've been talking through this idea of how do we match the right providers with the demand for patient care, how do we ensure that the registration process of providers on our island are standardized and easily accessible for those who need to make decisions? So we turn to a digital system for our health professional registration. That way we have all the documents, we have all the skills, we have all the services that are provided in a single database that we can pull at any time when we're looking at gaps within our system. So there's a lot of the ecosystem that we're continuing to build out. And it never stops. This idea of health information and getting better data never stops. And while it's a complex issue, we've started to look at the nuances within the data that we're collecting. And we understand that while it's important to have high-level health data, there's a lot of building blocks below the surface of the data that we often share with each other that needs to be robust as well. So if you think of our ecosystem, we have providers in our ecosystem for health information. We have the services that are provided to patients. We have things like population demand. We have epidemiology data from our epidemiology department. The hospital provides us data. But beneath that, how do we ensure that that data is clean enough to be able to say something good about it? So what we've been doing over the last few years is also trying to get to the nuances and the details of the data and ensure that the data that we have is clean, as I said. So we've implemented things like unique patient identifiers. So everyone on the island of Bermuda within a system that we have is assigned a unique patient identifier. What that does is ensure that no matter where the person goes within the system, there is a way to say that this person is the same person from one setting to the next. And by doing that, you can match that against, for example, a care pathway and say, is this person following the right care pathway or efficient care pathway that will allow them to get the best outcomes that our system can provide? Along with that, you can pull information such as demographic information from the patient and say, okay, well, the outcomes that we receive as a population, what does the demographics of the cohort look like? So unique patient identifiers, which we believe is a foundational unit within our information systems in general, whether it's done on paper, whether it's done in a digital platform, is an important part of ensuring that we're getting the right matches to the patients and the system that we have. And then if we take a step up, we're looking at, okay, well, if we can identify the patients, can we identify or ensure that through our health information systems that we are identifying the settings that they are going into and the services that they are providing? So on top of patient identification, we've also done things like identify health professionals. So every health professional has a unique identifier, and every health business is also assigned a unique identifier. So just on that piece of foundational data, you can go into a system and you can say, okay, well, I understand where the patient's going. Now I also understand where the settings that the patient is receiving services from, and what other settings, what other services are being administered through those settings, or what kind of skills the health professionals within that setting have. Because if there's a mismatch between what the patient is seeking and what the health professional can provide, at least now we have the data to say that, okay, is there a gap in our health system ecosystem that we need to fill by investing more money into a certain resource? So those are some of the nuances that we've learned. We've learned that having the right diagnostic coding and procedure coding is key for understanding what kind of population health concerns that we have. Right now, we use CPT codes, current procedural terminology, and ICD-10, which is one of the most recent ICD-10. I think they've moved on to 11 in some ways now, but we're using ICD-10 to standardize our understanding of what's going on within diagnoses. We also do things like consolidated data sets where we take a lot of data together and put it into formats that can tell a bigger picture to the public and to decision makers. And we use surveys to supplement that information as well. But one of the things that we've also learned, again, is that while we can look at the technical information around patients, providers, services, we also need to not take it for granted that our websites, our social media, our service listings, our content that we have on our various public-facing things provide a very essential part of linkage to our health information systems. So in the Health Council, we genuinely believe that good data, and just to caveat that, and an ability to effectively share that information is the best key to unlock the secrets of better health and healthcare. So as we've gone through this evolution of looking at our data and looking at our data ecosystem, we've been able to develop better population health strategies, whether it be around health system reforms, better policy decision-making, population health programs. We're using it to define our core benefits, or what we're going to define as essential things that everyone within our health system should have access to, which goes into our universal health coverage kind of decision-making. We've looked at it in terms of pharmaceutical procurement and distribution. One of the key conversations we're having right now is around workforce development. So we're developing a better population health platform through these various pieces that only can be populated or put together if we have data to back it up. And as I said, the data has to be nuanced at various levels if ultimately we're putting into play all these different pieces to ultimately get to a better quality of health and quality of service provision for our population. Again, this has to do with a patient-centered approach, and we understand that developing all these pieces of the puzzle should lead to better health. But we understand that health is a complex thing. We did a recent thing, a recent kind of data dig recently when it comes to the life course of an individual, and how do we look at life course and the different deviations in health that a person can go through as they go through pregnancy, infancy, childhood, all the way to older adulthood. Because again, data is not just there to run numbers, it's to help in making decisions and to help a population to achieve the best health that they can have as they go through our life course. So not only do you need to understand what's going on within your health information systems, but we feel it's extremely important to match that to our understanding of what our populations are going through. And it's complicated and it's very complex, and a solution to a complex and multi-layered problem when it comes to our health and the solutions that we have when it comes to respect of tools that we're using within health information systems are often not simple. And I have to give it up to our digital health strategy committee, who has come up with kind of a gold standard approach to what a platform for consolidating the various pieces of information and the access to that information can look like. Again, a complex problem sometimes requires a complex solution, but it has to be a complex solution that is properly planned out, that understands the nuances of the health information systems that you have to bring to bear, whether it be epidemiology systems, hospital systems, community provider systems. All these different systems have to come together. Knowledge, demand, all these pieces of information need to come together to create a system that's going to work for everyone and achieve the ultimate goal, as I said, for us, would be a more equitable and quality healthcare system. So this is an example of some of the work that some of the experts are doing when it comes to trying to put together a map for what our health information platform would look like, and the functionalities and the different outputs that we would get from it. So looking at health information systems in general and going from this frame of what are we trying to accomplish, what journey have we gone through in terms of looking at our administrative data and building it up to something that's more complex in terms of ecosystem, and looking at our health data and our understanding of our population and trying to build something more complex to deal with complex needs. We feel that we're in a pretty good position as a local community to enhance our patient care with robust health information systems, to improve our policy decision-making, to be proactive in our public health interventions. Once we understand what the forecast for epidemiological outbreaks and so forth are, we can put in timely interventions, optimize our resource allocation through better data-driven insights, our workforce, making sure our workforce is right-sized for the demand we have, creating comprehensive coverage for the type of services that we need, and ultimately doing things like having innovative health solutions. We feel that we're in a pretty good position to do so with what we've done in terms of our strategies and the foundational work that we put together. And so we have this commitment to excellence. As an organization, the Bermuda Health Council is committed to harnessing the power of our health information systems and continuing to improve on things to build a resilient, efficient, and equitable health system. But we know that just an island of Bermuda by itself, while we can achieve a lot, it's extremely important to have regional partnerships in our journey towards better equity and better equality in our healthcare. So it's going to require an ongoing collaboration. So I'm extremely grateful that this community practice has been put together to share best practices, whether we're sharing with you and we're learning from you. There are points of blind spots that we may have that you may have full insight into. our region has to come together around these things to be able to ultimately come up with a solution that is not only good for ourselves as a country, but good for our collective as a region. So together we can create a healthier future for all Bermudians here on this island, but also for the residents of all our collective countries. But there are a lot of layers to that onion that we have to peel, and we have to understand the health information systems, as PAHO has always taught us, is not just about a digital system, even though in Bermuda we're looking to digitize our entire system by 2030. It's not just about the computers and technologies. It's also about our strategies and our intent for how to use information to do the things that I said that we are already in a good position to do, but as we as a region can do collectively. So I do really want to thank UE for putting this together. As we know, a rising tide of, and specifically in this situation, rising tide of information lifts all boats. So I look forward to the journey that we're all going to go through by sharing information, by determining what our best practice and our standards are going to be as a region. And we're happy as Bermuda to contribute as much as possible. I know we have really good experts here in Bermuda, as we do across the region, but the conversations have to go on. So I just want to thank you for the opportunity to talk about what we're doing as a snapshot in Bermuda, and I look forward to the conversations not only today, but going forward into the future. Thank you very much.
Thank you, Dr. Brathwaite, for that very insightful presentation. So now we move to a question and answer session. And we do have some questions in the chat. So I'll begin. This question is for Dr. Brathwaite. The unique patient identifier, is this the same as a national ID, or is it separate and available to all individuals living in Bermuda?
Yeah, so
a second. Go ahead, I'll ask after.
No, you can go with all the questions, I guess, and I can answer it just for efficiency.
And then there's a second part to the question. How long did it take for you to implement the unique patient identifier, and what was the methodology?
Yeah, so in terms of national identifier, there was a decision made probably 6 or 7 years ago to segment out the health identifier and whatever potential for a national identifier or electronic identifier for everyone on the island. The process of coming up with the unique patient identifier is still an ongoing process. We've allocated or assigned everyone a unique patient identifier through an algorithm that we worked with a third-party company with, and a system, a platform that we built specifically to house that information. And that process probably took 2 years to put together. It's the next phase of taking that unique identifier and putting it across the health system that we still have work to do. Not all of our system is digitized, so a unique patient identifier really does need a lot of digital infrastructure to really be as effective as it needs to be. While you can write it down on paper, it does need a lot of additional work. And so we are working with it within probably a larger platform now, a larger kind of strategy now on how to implement that unique identifier. But it has taken a number of years, but we are happy with the idea that we have a methodology. We have assigned individuals this. We are just now in our implementation phase on how do we use it across our health system, and how do we get all the stakeholders to buy into the idea that everyone should have one single identifier as a grounding factor, a reference for decision making across our system. So that's for unique identifiers.
Okay, so I think we have a related question to that. You may have answered some parts of it already. Is this a national identifier? And if so, how was it accomplished? And was it developed by a private company? Is it a separate database of patients and IDs?
Yeah, so, sorry.
Okay, well, okay, and the last part deals with presentations, and I will speak to that after.
Yeah,
go ahead.
Just to kind of go further on the question on identifiers, we had to go through the various identifiers that already existed within the system to see if any of them could be used to serve as an identifier for the country for health. And we realized that there were limitations to all of them, and there were different standards that were used. So we had to, in essence, start from scratch for the unique identifier. It was the algorithm was developed from a private company. It is a separate, so there is no linkage between the identifier platform and patient records at this point in time. What we would like to do is create over time some linkages to be able to say this identifier, this pool of identifiers can be used to link directly to patient records. But right now, from a security and a privacy standpoint, there is a reason for keeping those things separate. In terms of the presentation, at least for Bermuda, we're happy to share. And there, I know there's some other questions around identifiers. So happy to take some of this by email, if not to focus on just this part.
Yeah, so I'll flip over to another question, and then we can come back if you have more time to speak to the unique identifiers.
Sure.
Question. But in terms of the presentations, the presentation would be shared after the session with all of the participants. So I do have a question for both presenters. So Osbert, I'd hand this over to you first, and then Ricky, you can chime in. What have been the two biggest challenges to the development of effective health information systems in your country, and from your experience?
Okay,
Go ahead.
thank you. All right, thank you. So one of the biggest, I think it has to do with buy-in, user buy-in, to patient buy-in, doctor buy-in, and change management. That is the biggest roadblock to any of the implementations we have done so far. It's all well and good to have a software and to have persons ready to go and training and so on, but without the buy-in, we have had hiccups. And so I think that's one. The second hindrance has been whether or not we know what we want. Sometimes we think we know what we want and we are going it alone and we have our own ideas, and then we start and then realize that's not what we want. And in my experience with data, one of the things we're looking to do now is to reach out to stakeholders to see what data is required. And then we can look to see how we can get this data for meaningful use and for decision making. But those two things have been the drawbacks of, to answer that question. Thinking we know what we want and not having the resources to accomplish what we really need to do. Not having all of the expertise. We're small islands. And so that is one of the reasons why we're really excited about having a collaborative effort with UWI, a community of care, PAHO, all these stakeholders to drive these implementations.
Thank you for that. Yeah, sometimes we really need to look at the end point so we know where we need to go and how we need to plan for that. So I would now hand over to Dr. Brathwaite. The same question to you.
Yeah, I guess there's a number of layers to the question on the challenges. And I tend to maybe philosophize on this a bit, in that the biggest challenge to health information systems is understanding what you're trying to achieve in the health system and having collective buy-in to that goal. Whether it be trying to reduce the amount of chronic disease or trying to just enhance the quality of life, whether it be trying to understand better the social determinants of health. The challenge, the biggest challenge I see is just being able to articulate to the various stakeholders what the end goal is. And once that goal, that challenge is overcome, then it's about resources and coming up with the right systems and the right data structure and right standards to be able to build on top of that. But there's this foundational kind of, and I've seen it in various, whether it be in the US, in federal government, there's I don't know if it's a urge to just build systems and to throw technologies on top of things, and without kind of the foundation of what are we trying to accomplish? What are we trying to answer? What are our population health issues that we're trying to resolve? Without that, all you're doing is just throwing technologies onto an unresolved or undefined issue. And so some would say, well, you don't know the issue until you have the data within the health information system. And I don't know if that's necessarily the case. I think we have enough manual platforms over time to understand some of the issues, but just coming to a consensus with stakeholders as to what those issues are and prioritization of it I think is the biggest challenge. You know, and as I said, secondly, is just the resources, which of course comes with requirement of money, right? You have to have money to afford the resources. One of the things that someone said and have been saying a lot recently is artificial intelligence is going to be a game changer for a lot of these things. So hopefully we're all on the cutting edge of artificial intelligence within our health information system infrastructure to help resolve some of the resource challenges or the inability of us to have all the skills and all the expertise that artificial intelligence can supplement that in a way that we can do it better with what we have.
Okay, thanks. You know, and coming out of something that you spoke about, you alluded to it, and we're putting technology upon technology, but then we also have persons who are you going to be using the technology? But how do we convince them that the technology is going to produce what we're really looking for? So then that brings in the whole aspect about change management and getting people on board with what we want to do. Same thing Josiah spoke about in terms of getting people on board and really buying into what it is we're trying to do. Okay, so I will move on to another question. Okay, so it was, how is ICD-10 implemented in your health information systems? Were clinicians trained to use the ICD-10s?
Yeah, for Bermuda, I can say that we set a deadline, whether everyone agreed to a deadline or not. We set a deadline as to when we were going to change. I think first was a realization that ICD-9 was so outdated that we were using such, and I know some people still use it, but we realized that ICD-9, we were using such a kind of an outdated way of coding that we had to make a move. So we set a deadline, and then we had a number of in-person training on the coding by expert coders for the health professionals themselves. And so as long as they were trained, there was no pushback to converting to ICD-10 in practice. People just needed to become aware with the nuances of it, and we did some coding on it, and it's still a work in progress. So we still have to go back, and every so often we have to provide training, but it does give a much more rich data set to work with.
Okay, thanks for that. So we have some more questions coming in. Okay, a question asked about which category of medical professionals were the greatest challenge for buy-in to the health information systems? Great question.
I could start. I'm going to need these persons, the physicians. So I'll keep the answer simple. It's easy to have most of the staff buy-in. The problems come, or the difficulty come, when you are asking a physician to basically change the way he practices medicine. That's how it comes across in his or her mind. And so the way they record. So what might take 2 seconds to write in a paper, they now have to do that digitally, and they have to follow standards, different data types, different ways of entering stuff or data. And so I think that category has been the most challenge, or the greatest challenge in any of the systems being implemented. But we still love them, and I still need them.
Bermuda, your end.
Yeah, so I think, so I don't know if the most challenging stakeholder, but I think the ones that are most invested in some of the health information systems, just from a patient management standpoint and a direct kind of, I wouldn't say ownership of a patient's care, but our physicians. So they are the leaders of patient care. And while other individuals have to use information systems to supplement and support the care, I think physicians have to be listened to and heard, because they play such a pivotal role within a health system, that it is for them to determine some of the functionality of these systems versus the other way around with some of the other health professionals. So everyone's important, but I think physicians play a very key role. And so it's just challenging to ensure that their needs are met, since they play such a pivotal role. I don't think they're challenging personality-wise per se. It's more so just understand the intricacies of what they do and trying to build systems around them without disturbing their ability to manage the complexity of care that they have to manage.
Okay, we have another question around the unique identifier. The reality is that, as important as it is, many countries in the region are really slow in getting to this point of having the unique identifiers. Can you share with us, Dr. Brathwaite, how the unique identifier was sold to the policymakers?
So I think this was a multi-ministerial kind of conversation about unique identifiers. I think from a policy or a political standpoint, just selling it to cabinet was, what is the advantage of being able to share digital information across not only the health system, but to use that as a, I don't know if you want to say a pilot or a representation of what a system, an economic system that can do more efficient transactions with more standardized data could look like. And so I think the conversation was not only about how it's going to help healthcare to become more efficient, the provision of healthcare, but just thinking about unique identifiers and the idea of electronic transactions across the system. How can that be used as a tool or a proof of concept for a broader system implementation? And I think that sold the various ministries on the importance of it. And that made it easier for them to buy into the idea that health could be a leading force of change when it comes to standardizing a unique identifier for persons. From the public, I don't know if the public, as long as you tackle the issues of privacy and confidentiality and ensuring that you're not collecting anything but meaningful data. Again, data collected should only be meaningful, which means that extraneous data that doesn't need to be collected shouldn't be collected. But as long as you have a reputation with the public and you can ensure the public that any data collection activity is going to be only meaningful and it's going to be a benefit to them, I think that's the first of a conversation, the start of a conversation with the public. But the politicians is, how does it help the country, not only from health, but from the various ministries that they kind of oversee.
Okay. So there is a comment from Dr. Potter. Dr. Potter, is it that you'd like to come on mic and ask your question? If so, please feel free to unmute and ask your question.
Someone may need to unmute Dr. Potter.
But if I understand the question, and maybe I'll just preempt. So I agree, health information systems are beyond just kind of clinical decision support systems and clinical systems. We've looked at health information systems as tying in also the nonprofit sector, various social determinant of health kind of organizations, the public into feeding into a health information system that understands that there are various variables that have to interact to ultimately lead to better health outcomes that aren't just traditional health services delivery systems, right? So I agree, it's bigger and it has to be an integrated framework and a strategy for taking all the data within a society that's relevant to health outcomes, to be able to come up with the solutions that are needed. Yes, and it's beyond just kind of just a hospital system or a doctor's office system. It goes well beyond that when it comes to health information.
Okay, good. I think we've had a very lively discussion. Thank you so much for that. I'm cognizant of the time. I see it's now 11:20. We do have one other presentation to go, and that the presentation is a presentation delivered by me on the community of practice. So persons who still have questions, you can leave those questions in the chat and we can always respond to them afterwards. We will also, as I said, be sharing the presentation with you. This presentation will give us some information with respect to the Caribbean Information Systems for Health Community of Practice. And again, I want to say it's called CARISHCOP. So I'll give you some information with respect to the origin. The idea of a community of practice in the Caribbean actually came about from the voices of people in the region. So while we were doing some other work with respect to developing of a technical support facility in health information systems, we spoke to a number of stakeholders, and coming out of those discussions, we actually had people speak to the need for this space where people can share information, share their challenges, get some ideas as to how they can move forward and have some vibrant discussions. So really this idea originated with you from those meetings that we'd have had and the numerous discussions. So now that we have the CARISHCOP, what is it? It's a network of persons with interest in information systems for health and digital health. And those persons who will react regularly to share, as we said, best practices, it will be a space for exchanging knowledge and experiences and to be innovators in co-creating the path for advancing our health information system in the Caribbean, because we're all in this path where we're seeking to strengthen what we have and advance it. And we actually need to depend on each other to help us move forward. There's no need to reinvent the wheel every time. We all have a system in place. Our colleagues are doing things and we can go follow what they have and we can share the experiences. So in terms of where it will be located. So the operational hub for the CARISHCOP, it will be at the University of the West Indies, the HU Center for Health Economics. There it will both managed and operated by a team here at the HU. So in terms of a little bit more, so we see it as a space where we will be meeting and having these vibrant discussions and sharing information. But we want it to be something that's complementary to what has been happening already in the region. As we spoke to things that has been happening with respect to information systems for health, the work that we've done with PAHO and so forth. And this is really an arm or a pillar for advancing what we want to do in the region with respect to health information. So it's complementary to what's happening. And with that, we also see it as something that needs to be in alignment with what countries have already done. And we're saying that countries, we already have strong country stakeholders who are doing work in the region. We have technical and financial partners doing work with us. And then we want to speak to some of them. So besides countries some are more advanced than others, but others are coming along. We do have the key partners. And we speak here of CARICOM. We have CARPHA, the OECS, PAHO, USAID, CHISU, many of you who are on this call right now with us. So in terms of the expected membership, so the membership really will comprise of a responsive pool of experts, both national, regional, and international experts in the digital health space. But we also expect to have persons who are non-experts, but they just do have vested interests in this area. So it's the whole mix of persons who are in the field and those who would have some interest that we'll now be able to learn from those persons. And it is the whole talent pool that we want to create. In terms of the engagement, there will be some rules of engagement on membership in terms of how persons can join, the procedures with respect to how persons who should be in, who should not be in the community, and what are some of the rules engagements, what we have the platform operationalized, how is it that we expect it to operate on the platform. So there will be some engagement rules. There will be the administrators who will be looking into the community of practice and following our members and making sure that the discussion continues. It's not just placed there, but that we can progress the conversation and progress the learning and progress the knowledge sharing. How do we join in terms of joining the Courage Cup? In this first instance, what we'll be doing, the persons who are actually on this meeting, we'll be sending out invitations to you with the relevant link to be able to join the Courage Cup. We will also send out the general information with respect to what are the rules of engagement and so forth. And this will happen in August. So the community of practice will now begin, and you will be the first set of persons who will be forming this community of practice. Again, it's not just something that's going to be a one and done. It's an ongoing platform for engagement. But while we do that, we also want to bring together people in one central spot for things like this, what we're doing today, having us come together and sharing what's happening in our own countries in a forum such as this. So our next event is intended to happen in October 2024, and you will be hearing more of this from us. So that's just a little bit, a very synopsis about the Courage Cup. And today is the day we're having our launch, and you're part of this launch with us. And part of the launch really speaks to a logo, and the logo, we're going to have a reveal of our logo, and I shall. So there you have it. This will be the logo for the Courage Cup, our newly minted Caribbean Information Systems for Health Community of Practice. So colleagues, and I'll come back to you here to ask. It's now 11:27 in the last final few minutes. I'd like to ask if there are any comments or anything anyone would like to share with us before we end today's session. You can feel free to open your mic and just make the expression.
A great show. Dr. Robin Roberts here from Nassau, Bahamas. When will the recording be available? So you know, I got quite a few folks here who would, I'm sure, be very interested in hearing the talk.
Yes, we'll have the logo available. The presentation available as soon as we're finished with this session. We'll do a little cleanup of it and everything, and we will be sharing it within this week.
Thank you.
Okay, Dr. Robin Roberts. Anyone else?
Hello, good morning. Kadesh Bailey from the Medical Benefit Scheme here in Antigua. A very good presentation by the presenters, and there was a lot of information shared. I definitely feel like the persons who presented were warm and willing to share information and be part of the group. I'm excited to be here, and I look forward to us collaborating and developing some new strategies with this new initiative. Very good, top notch.
Thank you very much for those comments, Kadesh. And we'll take a final comment from anyone. So just to highlight some of the chats. Thank you for everyone who's actually making expressions about the session being excellent. Glad to be part of this initiative. Excellent initiative. Looking forward to next steps. So with that, I would like to say thank you very much to everyone who would have taken the time out to be with us here today. This is truly a memorable day for us here at the University of the West Indies HU Center for Health Economics, and we thank you for sharing your time with us. Until we meet again at our next event, and until you hear from us with respect to the invitation to join the community of practice, I say thank you, have a good afternoon, have a good morning, and for those on the other parts of the world, have a good evening. Take care and goodbye.